Dr. Moran, how are you? This is Josh Prall, and I'm a physical therapist, as you know from reading my resume. I developed a special interest when I was in school, the low back and the lumbar spine. So I did a systematic review of low back pain and radiculopathy. All right, so it'll be about 5 to 7 minutes, and I have 11 research articles. Okay, so I titled this research article, I typed the systematic review of physical therapist interventions for patients with low back pain and associated lumbar radiculopathy. Okay, so for starters, the prevalence and cost with low back pain. So low back pain is the 5th most common reason for a U.S. office visit, right? And it's the 2nd most symptomatic reason for somebody to go to the doctor. So basically, it's out of everything you would go to see a doctor for, low back pain is the number 2 reason why all across the country people are going to see physicians. Low back pain is the most common cause of activity limitation in people under 45 years old. Okay, that's where a lot of disability comes in, and over $100 billion in total healthcare costs per year go to low back pain, which is a staggering price. So in 2014, a group of physicians got together, and they basically got together and they came up with guidelines for low back pain. And the title of the article was Worsening Trends in the Management and Treatment of Back Pain. And the conclusion that they came to was that the well-established guidelines for routine, non-specific back pain need to stress conservative treatment, including education, the use of NSAIDs, so your Aleve, your Advils, acetaminophen, and also physical therapy. And you absolutely need to avoid very aggressive treatments like opioids and surgery and injections. And then the other thing about the opioids is, of course, there is a staggering addiction rate with opioids nowadays. So it's another reason why they're really just saying stay away from opioids, stay away from surgeries, because surgeries do not have a good success rate. In my practice, when I used to work in the outpatient setting, I would see so many people that would get a total knee or total hip replacement, and they would be prescribed an opioid, or even a back surgery, and they would be prescribed an opioid. And these are people that have they're on it for 2 or 3 months, and they have a very, very hard time coming off of it, and it's not good. It's a very sad thing. But low back pain and radiculopathy, when you combine those two together, it makes up a very small percentage of all cases of low back pain. Usually it's just low back pain, okay? But the systematic review that I did was on low back pain and associated radiculopathy. So when you have radiculopathy and you put that in the equation, you have increased symptoms, you have increased disability amongst people who work. Okay, you have and then you have increased in healthcare costs. People that have the radiculopathy on top of the low back pain, okay, make up about 60% of the people who are out of work with low back pain issues. Okay, so the purpose of this systematic review was to evaluate the literature and regarding the effectiveness of physical therapy interventions in the treatment of patients with lumbar radiculopathy. So low back pain with radiculopathy, a shooting pain down the leg. Okay, some of the methods that I used search engines like ProQuest, PubMed, Pedro, Google Scholar, and some of the search terms I used was sciatica, lumbar radiculopathy, or radicular nerve pain, and lumbar nerve root pain. So sciatica is that term that you hear very often, and that's that pain, that shooting pain that people talk about that go down their leg. Sciatica and radiculopathy are synonymous with each other. So the inclusion criteria, all right, so to be into the systematic review, it had to be a randomized control trial. The adults had to be 18 years of age or older, and their chief complaint of pain or paresthesia in the lumbar spine had to be below the gluteal fold, so it was going down into the leg. The exclusion criteria was any interventions or techniques that were performed that were not performed by a PT. So chiropractors do a lot of lumbar stabilization, manipulation, stuff like that. Osteopathic physicians, so you've got the MDs who are the medical doctors, and the DOs, the doctor of osteopathic medicine. Those DOs also can do spinal manipulation. So but it had, the inclusion criteria had to be a physical therapist who was performing the methods. So the results were as followed. The physical therapy interventions, all right, consisted of the following: lumbar traction, okay, pulling the spine, right, decompression, extension-oriented treatment approach, extending the spine. There's a whole treatment approach behind that about, decreasing the disc and putting the disc back into place. Core stabilization exercises, a combined approach with all three, acupuncture, low-level laser, and ultrasound. Okay, let's see here. So, education and advice. The level of evidence for this was pretty fair. Okay, and there's a lot of information out there regarding the anatomy of the spine, the pathogenesis of a herniated disc, and the natural healing process that goes on, okay, without surgery. Because that's the big thing. You don't want to have, you don't want to have surgery. And all the education and advice papers really emphasized sciatica, which usually has a positive prognosis. So if you just have low back pain, you have a worse prognosis than if you have sciatica. Because typically if you have sciatica, it's due to a herniated disc, and with decompression and some extension therapies, they can be cleared up. So traction, okay, the level of evidence for that was pretty good, okay. The limitations were the inversion traction table, okay. Not every table is made the same. If somebody used a table that was 30 years old, you might not get the same traction to decompress the spine as opposed to if you used a table that was brand new. You're using it for the first time, it's really going to have a good pull and be able to pull the spine apart and cause that decompression so that the disc isn't right in on that nerve. The extension-oriented approach, okay, is extension of the lumbar spine with the goal of producing a centralization. Okay, so proliferation is when the nerve root goes down the leg. That's called proliferation. Centralization, okay, you know that you're getting somewhere with this treatment when your symptoms start to centralize. So the pain, instead of going down your leg, now it's centralized to the low back. Okay, now you're starting to decompress that nerve root. So that's a very good sign. Okay, stabilization exercises. The level of evidence was pretty good. So it's mostly core stabilization exercises, planks, what they call dead bug stuff for your low back, your glutes, your obliques. We've been in therapy. I can tell you, I give everybody that comes in with low back pain, I give them a core stabilization exercise. The evidence for core stabilization exercises in low back pain and in low back pain with radiculopathy is really good. The combined approach, okay, it looked at combining the centralization, the traction, and what's called spinal mobilization. Okay, so spinal mobilization is that grade 5 manipulation, that adjustment that you hear in the chiropractic offices, okay? That chiropractic offices, again, that didn't meet the inclusion criteria, but they, like I said, chiropractors and osteopaths do spinal manipulation, so do physical therapists, and they do it very well. So the combined approach showed the best level of evidence. The laser showed a very small level of evidence, and in fact, the research studies basically said that there was such a small change that it was almost not even worth talking about. Okay, the ultrasound was also the level of evidence was weak to fair. It showed a small change, showed small reductions in pain, but not enough to really consider it a really good intervention. All right, so the discussion part of this, okay, the question still remains as to which intervention would be the most appropriate and yield the best results in patients with radicular symptoms. Okay, so my systematic review looked at many interventions, but there's still pretty much a lot of research that needs to be done to confidently say which treatment would work the best. So far, we know that some work okay, but there's not one gold standard as of right now. And that's good to know. Again, I put everybody on a lumbar core stabilization program, and I like to do spinal adjustments when it's not contraindicated. If somebody has a fracture, you can't do spinal adjustments, stuff like that. But those are the two, anecdotally, that I have found work pretty well. So clinical relevance, although many treatment techniques were used for treating patients with low back pain with associated radiculopathy, there seems to be evidence that some physical therapy treatments are moderately effective, such as education, traction, spinal mobilization, and then extension, that extension program. Okay. So spinal stabilization, usually spinal stabilization, which is that core stabilization, usually that's works best in combination with other interventions. That's what the research says. I can tell you in the clinic, a lot of people start there. They start with core stabilization or spinal stabilization, however you want to say it. And what the research basically says is that's probably not a good place to start. Maybe like modalities, heat, electrodes, ice, stuff like that might be the best place to just start right away, and then go into spinal stabilization once the patient gets a little better. Okay, so the conclusion of this is that I looked at high quality randomized control trials that were very effective for physical therapist intervention in the treatment of patients with lumbar radiculopathy. Like I said, more research is needed to confirm subgroups to determine which specific interventions were the most effective. So the limitations of this study, I only focused on articles that involved the treatment or treatments performed by a physical therapist. The reason I say that is because there are a lot of really good research articles talking about spinal adjustment. So what you think of when you think of going to the chiropractor, that crack in the back. If you look that up with chiropractors and osteopaths, there is so much good research out there for that specific technique. And also, and again, so that was one of the limitations. And, I eliminated chiropractic and osteopathic research altogether. Okay, so anyways, that is my presentation. I have had a lot of these articles I developed through PT school, and at my first job we did journal articles once a week. We all got together and went through journal articles because in physical therapy you're always doing like what's the best evidence-based practice. So whatever the evidence is showing is the best out there, that's what you want to be doing. So anyways, Dr. Moran, I thank you for listening. I hope you enjoyed it, and I look forward to hearing from you soon. Thank you.